we start, Prof?
Yeah.
But I think the second chair not here. Never mind, we start off first. Okay. Good morning, good afternoon, good evening to all. And first of all, I'd like to thank all the speakers, chairs, and commentators for supporting ACNN. And I wish all of you a very happy New Year 2023. Today, we are very fortunate to have Professor Ashish Kumar with us, and Professor Ashish Kumar is an assistant professor, neurosurgery, Sandy Broad Health Sciences Center, University of Toronto, Canada, Ontario. And his topic today will be aneurysmal subarachnoid hemorrhage, recent trend in management. Our second speaker will be Sister Shani. Sister Shani is a senior nursing officer attached to 𝒓𝒐𝒐𝒊𝒂𝒍 Institute Medical Sciences and Technology, Trivandrum, India. Her topic today will be critical nursing care strategies in the management of patients with aneurysmal subarachnoid hemorrhage. And our third speaker will be Mrs. Suchitra. She will do a case report on the topic of aneurysmal subarachnoid hemorrhage. And our chairs for today will be Professor 𝑑𝒓𝒐𝒊𝒕𝒊𝒄𝒂𝑍. He's the Associate Professor of Neurosurgery, Department of Neurosciences, Biomedicine, and Movement Sciences, University of Verona. Dr. Angela Gunadurai will be the second chair, and she's the Principal, Jubilee Mission College of Nursing, Madonna Nagar Kendra, Canara, India, sorry. And she is also the president of Neuro Sciences for nurses in India. And our commentators for today will be Professor 𝑑𝒓𝒐𝒊𝒂𝒍. He's the chairman of Neurosurgical Unit, University Hospital, Associate Professor of Neurosurgery, Medical School, Brazil, and also the chairman of WFNS Nominating Committee. Our second commentator will be Professor Dilshad Mamadena. He's the neurosurgeon, Republican Scientific Practical Center of Neurosurgery, Skull-Based Neurosurgery, Daskan, and Republic Clinical Hospital, Department of Neurotraumatology, Daskan. And he is also a member of 𝑑𝒓𝒐𝒊𝒕𝒊𝒄𝒂𝑍 Association of Neurosurgeons, Suchita Bentley Fellowship Alumni Association, Regional Responsibility Neurosurgeon. So may I call upon Professor Yoko Kato to say a few words before we begin.
Professor, please unmute.
Hi, everyone. So very happy New Year. And first of all, I would like to thank you very much, Mrs. E, to organize such a wonderful, very gorgeous, the first ACNN webinar. So already you introduced all of the today's guest. So I think today's main topic is subarachnoid hemorrhage. Ashish is the expert of this region. And also the 𝑎𝑝𝑖𝑜, and Dilshad is my student. And also 𝑎𝑝𝑖𝑜 is my teacher, yes, or friend, teacher, yes. So 𝑎𝑝𝑖𝑜 is one of my very reliable teacher and friends from Brazil. Of course, Alberto is the chair of the Fujita Alumni Association committee. So I'm very looking forward to all your lectures. Thank you very much. Thank you.
Thank you, Professor Yuko-Kato. Now, I shall invite Professor Alberto Alberti to introduce Professor Ashish Kumar and to chair the session. Thank you very much.
Well, first of all, I want to thank Matron Yi Cheng and the Asian Congress of Neurosurgical Nurses for this invitation. It's a real pleasure for me to be here. And it gives me a particular pleasure to introduce Professor Ashish Kumar, who is not only a great professionist, but also a friend. He did his first part of education and training and also a career in India, where he became assistant professor at the Nizam's Institute of Medical Sciences in Hyderabad. And then he moved to Toronto, where he is actually currently assistant professor of neurosurgery at the Sunnybrook Health Sciences Center. He was a member, he has been a member of several committees in many societies. He has been involved in many projects, research projects mainly, and he is author and co-author of several publications in international journals. His main interests are vascular neurosurgery, both endovascular and open surgery, and skull-base neurosurgery. And he also has a particular interest in education and training. So today he is going to talk about a very interesting topic, which is aneurysmal subarachnoid hemorrhage, recent trends in management. We all know that this kind of disease is really difficult to manage. So we are all very eager to learn from you, Ashish, these new trends in the management of subarachnoid hemorrhage. So please, Professor Ashish Kumar, you have the floor.
Thank you so much, Professor Alberto Felitti and Professor Yuko-Kato, Professor Antunes, and rest of Matron Yi Cheng and rest of the rest of my colleagues here. I would like to thank the Asian Congress of Neurosurgical Nurses to invite me to speak on the topic where everyone is actually way more experienced than me. Of course, this is a process and this is a journey. So I would like to present my perspective on this, and I would humbly, at the end, would request a lot of input from the panelists. So let me start here by sharing the screen. And I have okay, perfect. Is my screen seen by everyone?
Yes, Ashish.
Yes, yes,
Perfect. Thank you so much. Thank you so much. So as I said, thank you so much for inviting me here. This topic today, when I was thinking about it, it was such a vast and significant topic, which I think all of us know about it, about the morbidity and mortality associated with aneurysmal subarachnoid hemorrhage. When I was presenting this, making this presentation, I was keeping in mind a bird's eye view of the subarachnoid hemorrhage rather than just focusing on the surgical management, so that everyone understands what all is involved in the overall management of the patient. Of course, surgery is part of it, but more important part is the associated medical management and ICU care associated with aneurysmal subarachnoid hemorrhage. So today we are going to learn about aneurysmal subarachnoid hemorrhage and its management under 4 learning objectives. One will be underlining the incidence of aneurysmal subarachnoid hemorrhage. globally as well as according to the different continents of the world. Then we will go into briefly describe the radiology, the investigations needed for management of SAH and associated pathophysiology, what happens at the microcirculation level during this event and why this is so morbid. Then we will briefly illustrate the role of medical management and ICU care in subarachnoid hemorrhage, which is, I think, more important than the surgical part, in my opinion, because the patient once gets admitted, especially in the poor grade subarachnoid hemorrhage, spends most of the time in ICU in recovery after the surgery is done. And at the end, we will compare different modalities. We'll know about what are the modalities of surgical management of aneurysmal subarachnoid hemorrhage, including open surgery and endovascular management. So let's start with the incidence of SAH. And this article actually illustrates the worldwide incidence of aneurysmal subarachnoid hemorrhage according to different regions, time period, how it has changed over the period of time in early 1980s up to early 2000s, and how it is actually correlating with the blood pressure and smoking prevalence in the population. So this is a systematic review and meta-analysis, the one where I could actually find the incidence together across different parts of the world. It included 75 studies from 32 countries and had a total of 8,000 patients almost. And it relayed the information that global incidence of subarachnoid hemorrhage actually declined from 10.2 per 100,000 person years in 1980s to 6.1 in 2010. And this is a global incidence. General incidence, which we overall quote, is around 9 per 100,000 patient years. But it gives you the whole journey or whole spectrum, how it was earlier in 1980s and how it is now in 2000s. And there have been further few studies by different countries as well, which has looked into the same incidence rate in their own countries. But this is a meta-analysis. So it found that the incidence of subarachnoid hemorrhage reduced by 40% in Europe during this time from 1980s to early 2000s, reduced by 46% in Asia, reduced by 14% in North America, but increased by around 60% in Japan. And I'm not surprised, as my initial training was at Fujita Health University, and when I was seeing these patients coming with ruptured aneurysms, Japan has a very high incidence along with Finland, and we will see that in this data, which was shown in this meta-analysis. So they also showed that the relative risk for rupture in all women was high, and it was around 1.3, especially in Japanese women older than 75, it was 2.5, according to this paper. And in European women older than 75 years, it was 1.5. So it is very high risk in general in Japanese population. And it's relatively higher risk in Japanese females above 75 years. So this particular paper also showed, as I said, the incidence of subarachnoid hemorrhage reducing with every millimeter of mercury decrease in systolic blood pressure by 7.1%. So every millimeter of mercury in systolic blood pressure, when it came down, it brought down the incidence by 7.1%. I think this is a very important data, which we all know, but it's good to see the mathematical side of it. And it also shows that with every percentage decrease in smoking prevalence, the risk of SAH came down by 2.4%. So you can see the overall incidence dropping around from 1980s very high and coming down to early 2000s was significantly decreasing in slope. So both the trend of the systolic blood pressure and smoking prevalence reduced as the trend of subarachnoid hemorrhage reduced overall in the world. So this is what I was mentioning about this meta-analysis, that if you see from the far left, it tells you about the geographic location of subarachnoid hemorrhage, the global incidence around 7.9, and the incidence in various continents, including Europe without Finland, Asia without Japan and Finland separately had very high incidence 16.6 and 22.5, as we can see. And then the incidence is overall in Australia, New Zealand, North America, South America, and Africa. Overall incidence is mentioned on this column, and we can clearly see that there's a difference. And as I say, there are outliers in terms of Japan and Finland, where the incidence is very high. And you can see overall change in these 30 years. If you see here on the far right side, is all in the negatives. That means that the incidence has reduced overall in all continents, except for in Japan, where the actual incidence has increased. And that was the I think the summary and the key point out of this meta-analysis. And we know this from beforehand when we talk about 𝑝hases score, for example. 𝑝hases score is a predictive score for any unruptured aneurysm. And we use this very often here when patients ask us what is the percentage of risk, although it is very hard to quantify. But 𝑝hases score actually takes the population as one of the major key contributing factors in determining the 5-year aneurysm rupture rate. As you can see, just the population of North America, European, and other than Finnish gets 0 points on top, whereas in Japan it becomes 3, and in Finland it becomes 5. So this becomes a very important point to understand the natural incidence or the natural history of aneurysmal rupture in these populations. So I think this becomes very important, and that's why it has been shown in the calculation of 𝑝hases score. Of course, here we also take into consideration when we are talking about unruptured intracranial aneurysms, about when we talk about the ISUA trial, that is the International Study of Unruptured Intracranial Aneurysms. When we talk about the 𝑝hases, we actually take the geography as well in consideration, whereas in ISUA, or in International Study for Unruptured Intracranial Aneurysms, the main focus was the size of the aneurysm. And we all know that how this can be deceptive. We all see smaller than 7 millimeter aneurysm coming with a rupture, coming with subarachnoid hemorrhage. But generally, overall practice here is to manage patients with smaller aneurysms, especially smaller than 5, in my opinion. And they keep them in close follow-up and follow them up with serial MRIs. So that's how unruptured intracranial aneurysms are treated. And I think this also gives us some idea about how many aneurysms, are managed medically versus surgically, except especially in this part of the world. So now coming to the second learning objective, we are going to see the role of radiology and to also see the pathophysiology associated with the SAH. We all know this is a typical picture of subarachnoid hemorrhage, where we see a hyperdense blood clot on a plain CT head with a relatively tense brain. And this has been classified as a Fisher grade or a modified Fisher grading. You can see on the left side, these 4 are the Fisher scale, and on the right side on these 4s are modified Fisher scale. And why it's important? It's important to know about the extent of bleeding, which can be 0 or no erect subarachnoid blood in grade 1 versus significant intraventricular hemorrhage or intraparenchymal hemorrhage in grade 4, because the risk of symptomatic vasospasm, as you can see in these red circles, increases with the extent of blood present in the brain. So the risk of vasospasm is less if the amount of clot burden is less in the brain, and it increases as the Fisher grade increases, and as there is diffuse deposition of blood in grade 2 less than 1 millimeter, more than 1 millimeter in grade 3, the risk increases to further 31%, and the highest is in the grade 4, whereas the risk of vasospasm is around 37, around 40% in Fisher and modified Fisher grade. So it depends on this. This is important to know. How to predict the future in terms of how the patient is going to spend his time in ICU, how much vasospasm he's about to get. So we know that CT angiogram and DSA are the 2 important diagnostic tools. If you have a very good quality CT angiogram, in my opinion, the role of DSA is very limited, especially in pre-op planning. And this is also one of the things which I learned when I was at Fujita Health Universities around 13 years back, when I was starting my journey in neurosurgery. And we published this article, especially about the role of 3D CTA in aneurysms. This was published in 2013. Of course, it was the work when I was a fellow at Fujita. And we could see the quality of CT angiogram at Fujita was so, in high resolution that you could actually, you can orient yourself. You can, even if you're planning for a surgical clipping, you can actually see how a pterional craniotomy view will look. And to be fair, I still, after 15 years, I'm not able to find the similar quality of CT angiogram. And I know it depends on software, but it also depends on various different places what we are equipped with. So here, if I have to evaluate a pre-op scan prior to a complex aneurysm prior to either surgery, either open or endovascular, and if the CT angiogram is not giving a good picture, especially in 3D pictures, I would have to take the patient for angiogram and to get a 3D DSA to understand it better. But if you have a 3D CTA, I think you obviate the need for a DSA, and that's very important. Now, coming to the pathophysiology of subarachnoid hemorrhage, we know that there are two major events which catalyze the microcirculatory disturbances. So when the blood comes out in the cisterns in a rupture, we see that there is the two important events which happen is there's an exogenous stimuli in CSF. So there is blood in the CSF, which leads to microcirculatory dysfunction, especially in involvement of CSF hemoglobin, presence of inflammasome-derived caspase and lipocalin. And when these stimuli generate the inflammation, what happens afterwards is hypoxia is aggravated with the release of hydroxyglutarate and HIF-1 alpha, which is a very important factor which has been found to stimulate hypoxia and microcirculatory disturbance. And this was very well illustrated in this paper in Lancet, where they focused on real-time metabolism during early subarachnoid hemorrhage and what happens at the microscopic level. And as I said, if you see this microcirculation, if this is the arterial and this is the venous side, these are small muscles which are surrounding, and the pericytes which are surrounding the microcirculation. In normal situation, the picture on the left looks like this. And when the subarachnoid hemorrhage starts in the early compensation period, you will only see microvasospasms of these microcirculations. The flow will still be there, but there'll be some microvasospasm which has been described. But when the brain starts to decompensate, you can see there will be a lot of platelet aggregation, leukocyte plugging, inflammatory factors causing thrombosis in these microcirculation, and that's how the hypoxia starts. And starts at the microcirculation level first, which leads to reduced blood perfusion to the brain. And this is a summarized picture of this article where they have shown the different kind of dysfunctions or abnormalities started to have when you have a subarachnoid hemorrhage, including mitochondrial dysfunction in terms of membrane potential collapse, apoptogenic proteins release, giving rise to neuronal swelling and programmed cell death, and microcirculation changes. As I said, it first causes pericytes contraction, very vascular smooth muscles contraction, which reduces the flow further in the microcirculation, and microthrombi formation, which leads to complete abruption of flow at the microcirculation level. So even if we see a CT angiogram, which we do for vasospasm much more frequently in the ICU stay, we will not see these changes in microcirculation, which are already in play once the SCH started. So this all leads to blood-brain barrier disruption, tight junctions loss, and pathological changes in the neurons, and leading to significant microstrokes which happen over the period of time. So that's how vasospasm acts, starting with the microcirculation leading to macrocirculation involvement of major cerebral arteries as the time goes by. So what tells us about this pathology is that you have to think bigger and wider than the surgical management, and that's where the role of ICU comes in, role of medical management comes in, where the key idea of keeping the patient intubated or sedated, especially in poor grade, is to relax the brain, maintain the cerebral perfusion, and reduce the ICP, maintain normothermia and euvolemia. The concept of triple H therapy is rather now shifting towards euvolemia, and make sure that there's adequate oxygenation level and adequate carbon CO2 levels in the blood, so that patients are not hypercapnic or hypocapnic. But if there is any problems with intracranial pressures, there can be a little bit of hyperventilation, not too much hyperventilation administered. But these are the key areas where an ICU physician focuses when he sees a patient with subarachnoid hemorrhage, and this has been very well demonstrated in various review articles, especially this with Springbrock this is a paper from Denmark, which actually tells us about all the secondary brain damage which happens after subarachnoid hemorrhage, including vasospasm, reduction in cerebral blood flow and perfusion, leading to increased metabolism, reduced hypoxia, reduced oxygen levels in the blood, and everything where involvement of multiple comorbidities causes increase in high blood pressure, increase in high ICP, and ultimately these are all the different mechanisms through which secondary brain damage happens. So the ICU care actually comes in at this point of time where you want to reduce the secondary brain damage. So you want to make sure that the cerebral perfusion is good, the vasospasm is minimal, patient does not have hypovolemia, patient does not have hypoxemia, and at the same time you have to make sure that there is no infection, there are no seizures, there are no associated factors. When the patient is lying down, chances of pneumonia is very high, pulmonary edema is very high. We also, of course, have to make sure that the ICP is normal, and we have to make sure that if there's a necessity, we have put in an EVD for hydrocephalus, because everything, including an ICH or increased CSF in the brain, causes increased ICP, which in turn leads to reduced cerebral blood flow, and which comes to these monitoring techniques which we usually employ in ICU, including ICP monitors, EVD drains, checking the vasospasm with transcranial Doppler, CT perfusion. We do a CT perfusion at day 3, day 5, and day 10 at Sunnybrook here to follow the vasospasm and the perfusion deficits. We of course have cerebral blood flow monitors, microdialysis system, brain tissue oxygenation monitors in form of Lycox, and these are some other methods through which you can actually see the neurophysiology of the brain when the patient is in ICU. Now, why it is important? It is important because overall outcome of the patient depends highly on this. So that's, as I was saying, we do a lot of CT angiogram, and there's another article which actually categorizes the importance of transcranial Doppler. Cerebral microdialysis, it's not there at every center. Of course, it's not there in Toronto at this point of time, but it's in the research phase. People still use it in the labs where increases in the CSF lactate pyruvate ratio, glycerol and glutamate is associated with subarachnoid hemorrhage. And of course, we also sometimes monitor the brain tissue oxygenation levels. And the idea is to keep it around 15 to 20 millimeters of mercury. And again, these are some things which is also we have taken from traumatic brain injury patients where these things are also monitored. But in day-to-day capacity, transcranial Doppler is the most important test here, where vasospasm is monitored over the period of the patient's ICU stay. And we know that normal maintenance of magnesium and involvement of statins, antifibrinolytics, antiplatelet agents, ℓ therapy, as I said, has now moved towards euvolemia. And if suppose patient develops vasospasms, these are the important medications. So we actually start with also IA or IV milrinone along with nimodipine. And in milrinone has proven to be one of the key drugs to cause vasodilatation at the microcirculation level, which actually the idea is to try to reduce the effect of vasospasm at the microcirculation and improve the circulation at the level of capillaries. So, of course, fever, anemia, hyperglycemia, hypertension, hypernatremia, pneumonia, hypotension, pulmonary edema, as I said, these are important complications which can happen during an ICU stay, and that's why this also becomes very important from a neurocritical point of view. And that's why this was a paper which was published in a Finnish ICU study where they saw their mortalities and morbidities over like 16-year period from 2003 to 2019. They saw around 1,800 patients, and they saw that their mortality actually with a good ICU care declined over the period of time from early 2000s to 2019, and there was a general trend from 2003 to 2019, not a very significant trend, but it was a general trend of reduction in morbidity and mortality. So coming to the last part of why all this becomes important is ICU care goes along with the surgical care, because you have to make sure that the aneurysm doesn't rebleed, and therefore the treatment objectives of surgical management include reocclusion or like obliteration of the aneurysm as soon as possible. The idea is to do it within 24 hours of admission of the patient, and this can be done by open surgery or endovascular technique, especially those surgeons who are doing it both. I think there is an important part of a dilemma in their minds about what approach to take, and I will talk about that decision making more. But we know surgical management of subarachnoid hemorrhage includes standard. Most of the anti-circulation aneurysms are treated by open surgical methods, including cranial craniotomy, sylvian fissure dissections, aneurysm exposures. Many people use temporary clipping and then permanent clipping. With the help of these temporary and permanent clips, we make sure that the size of the clip, especially for younger neurosurgeons, are like 1.5 times the neck diameters. And once we are done, we use in ICG angiography during the procedure, and intra-op DSA can be done. So these are the different kind of clip orientations which we can use for ACOM aneurysm, depending on where the aneurysm is projecting. It is superiorly projecting, inferiorly projecting, anterior or posterior projecting. Every projection of the aneurysm is related with the perforators associated with the anterior communicating artery, and that's why it's important to avoid those perforators when we are planning the clipping. Similarly, for PCOM or MC aneurysm, sometimes we have to reform the whole bifurcation by using simple clips or by using fenestrated clips. And similarly for ICA aneurysms, sometimes we have to use a fenestrated clip here to go around the ICA and clip it for the one aneurysms which are ventral to the ICA. So this is in general about clipping, but more important part for, especially for those who are doing both the procedures, is how to decide whether to do open surgery or whether to do endovascular surgery. So there have been a lot of papers on from big centers which do both the procedures, and they have compared. And the traditional indications were narrow aneurysm neck for endovascular treatment, especially less than 4 millimeters. I'm not sure whether this is still existent. There are a lot of remodeling techniques where people use balloons or stents to close the aneurysms. But the traditional teaching was a small neck aneurysm is an ideal candidate for endovascular treatment, especially if the patient is old and they are able to maintain follow-up. So that's very important, because we know the only drawback of endovascular treatment, significant drawback, is the recurrence. So it's around 20% of recurrence. They are not definitive. Patient needs to be treated again and again in the follow-up. So it's important to make sure. And this was a problem when I was practicing in India, because apart from the financial burden, the follow-up was an issue. Patients coming from far remote areas, they were not able to come every 3 months, 6 months, 1 year for surveillance MRI and to see if the aneurysm is coming back or there's more refilling. Whereas in open surgery, the traditional indications were wide-necked aneurysms, the bigger and the larger aneurysms where you have to reform the neck, complex anatomy, or a branch which is incorporated from the dome of the aneurysm, fusiform aneurysms. Middle cerebral artery location was important in decision-making, if it is a complex or if it's a simple aneurysm. But usually for complex and MC aneurysms, the trend and still the preference of cerebrovascular surgeons is towards clipping. So it's important, and the other factors which are actually important is rupture, whether the patient has a ruptured aneurysm or unruptured aneurysm, because also depends on how you are going to treat it because of associated intracerebral clot. So the challenges in aneurysm surgery is based on a lot of factors in the form of anatomy and morphology of aneurysm, in the form of axis, how your ICA axis looks like from an endovascular point of view versus an open point of view, where is the location, what is the size and neck width that I said before. And more importantly, if in ruptured aneurysms, the most important factor, which I think is associated ICH. So if you are doing an endovascular procedure in a patient who has a significant clot burden, there's a high chance of that clot being liquefying and increasing more mass effect after you have finished coiling, because we use a lot of heparin to keep our catheters patent. So a ruptured aneurysm coming with a significant intraparenchymal clot has a high chance of deterioration secondary to liquefaction of that clot which is already there. So that's a very important factor, and most important factor in cases of ruptured cases. General condition of patient and a lot of intraoperative nuances, as I said, where the aneurysm is pointing, whether it's pointing associated without the associated perforators around it, whether the clipping can be done without involving the perforators. These are important challenges. So I would focus on decision making, and decision making becomes more important from a hybrid point of view, where you decide what kind of surgical approach to take based on what is the underlying risk factor, underlying nuances with that particular patient. So again, there's no general formula, but for example, a patient like this who had an unruptured posterior communicating artery aneurysm, and it's a thrombosed aneurysm with a small lumen. Patient has presented with mass effect, patient is presented with ptosis, and CT has shown this little PCOM aneurysm, which is just a true lumen, but there's a big clot around it. And in these situations, endovascular treatment will be a problem, because if you're trying to put coils into that small loop, that small remnant, what happens with time, the clot around it will liquefy and the coils becomes loose, and there's a significant early recurrence of the aneurysm. So in these cases, clipping is most straightforward, and you can decompress the large thrombosed part of the aneurysm, and you can actually let the third nerve recover early because you've reduced the mass effect. So when the patient comes with mass effect on the cranial nerves, surgical treatment takes a priority over the endovascular treatment. Now here, what if you have a large giant aneurysm in posterior circulation? The patient is also having a big aneurysm where there is incorporation of superior cerebellar artery, posterior cerebellar artery. This is one of the patients when I was in India. So at that point of time, we used flow diversion for these large giant aneurysms with some loose coiling to make sure that over the period of time, there is no significant instant thrombosis of the aneurysm sac, and the maintenance of the perforators are also key when you are using the flow diverters across basilar. So the idea of these flow diversion is they will generate the clot by generating stasis of the blood in the aneurysmal sac, and while maintaining the flow in the perforators. So as I said, for me, the most important factor has been the associated ICH in a ruptured status. So if there is a patient where I see a significant clot burden on the initial CT scan, and you can see the PCOM here associated with the clot in the temporal lobe, if it's not causing midline shift or mass effect even now, as soon as you take this patient to endovascular coiling, what will happen is that this all clot will liquefy and cause a significant pressure and mass effect. So you'll have to do 2 surgeries for this patient. You have to coil it first and do decompression afterwards. However, this is a candidate where I'll prefer surgery, open surgery, because you can decompress, you can release the mass effect, you can remove the extra amount of blood, which reduces the chance of vasospasm in future, and you can clip the aneurysm all in one single surgery. So for me, this is very important. As soon as I see an ICH, I do not take that patient to endovascular treatment. And this is very important to know, because there are so many students, learners, fellows who are seeing this, and you can see here the clip around the aneurysm. This is, I think, the last week's case which I operated here. It's important to know to set the balance right, and to see that every young neurosurgeon who is watching it, they know why this is being operated surgically versus not endovascularly. Similarly, same case, like this was like last month, 47-year young female presenting with this temporal clot. Again, similar picture, PCOM aneurysm, and we could see the post-op was better. There was no aneurysm recurrence. There's no need for a follow-up, and we could also remove the clot together. Now, as compared to posterior circulation aneurysms, which have a high chances of endovascular treatment because of the access and because of the ease of multiple gadgets which are there at this point of time, if you see multiple aneurysms together in a ruptured situation, you see that there's a flow-related aneurysms along the basilar artery and along the posterior communicating artery, which actually supplies the MCA on the left side. And you could see 3 aneurysms, which could be treated with one stent altogether, which has a flow diversion capacity, and we coiled the 2 other small aneurysms as well. Now, at the end, I'd like to show this case because this is a very important step in my career where I learned about a very new technique which I have not seen in my residency and which is still not very commonly followed here at this point of time. So this patient had a large paraclinoid aneurysm, had an acute SDH. Of course, if this was a complete unruptured aneurysm, there will be an option of flow diversion because it's a paraophthalmic aneurysm. But you could see that there's a large ICA aneurysm with a small waist just above the anteroclinoid process. So the issue here will be the proximal control when we are trying to clip this aneurysm. So in my opinion, this has to be clipped because there's an acute subdural on the same side. So we learned about this technique when I was a fellow at Fujita. With Professor Kato, we published our retrograde suction decompression assisted clipping experience, and this was the first time I actually saw a combination of a true hybrid approach of endovascular and open surgical approaches, where we published our own data, and we found it very, very significantly successful in having a control on large paraophthalmic aneurysms, where you need a proximal control as well. And you need to reduce the mass effect of the whole aneurysm. So for this patient, we employed the same approach. As you can see, this is a short video, and this is the only video which I showed in this presentation, because I think this is very key to know about this technique. And I think this technique is still underutilized in open cerebrovascular surgery, where you achieve a proximal control in the neck with the help of a balloon guide catheter. And then you trap the distal ICA with a temporary clip, and then you do a aspiration or suction through the balloon guide catheter, which will actually help the aneurysm to shrink. And then you can, what you were not able to see before, you will be able to see now. The option here was to do anterior craniotomy to see better, but if you see here with the retrograde suction decompression, you can actually see the neck very easily once the dissector goes under the aneurysm, which was not possible unless you do a suction proximally. So you can see the neck now very clearly, which was not seen even before because of the increased turgor. So once we do that, we are applying suction proximally through the balloon guide catheter, and we are putting clips into it, and the second clip goes in and also obliterates the neck proximal to it. So this technique, again, as I said, becomes very, very underutilized and needs to be done more, especially if you have a hybrid OR where you can safely go in with the endovascular balloon catheters proximally in the neck at the same time doing a craniotomy in the brain. So I think this was a very, very important milestone in my journey as a cerebrovascular neurosurgeon, and I think this experience at Fujita helped me to employ this approach and to see how combination of two things can lead to beautiful outcomes. So these are the post-op CT angiograms, and we can see the clips very close to the anterior clinoid. Once we completely exposed the neck, the procedure was done in like around 2 hours, so it didn't take a lot of time. Once we have the proximal control. So in summary, I will say hybrid approach, especially when we are doing open and endovascular surgery, is like walking the fine line. And because of my educator background, I always make sure that the decision making becomes paramount. So whenever a ruptured aneurysm comes, the decision you make also will look into the whole will decide the whole postoperative outcome. I have seen some of the colleagues doing, intervention techniques to coil the aneurysm, and there's a clot in the brain. and coming back for decompression 6 hours after the procedure. So I think decision making in all these different kind of aneurysms depends on what is the morphology, where is the aneurysm, anterior circulation, posterior circulation associated with an ICH. As I said, those key nuances are very important when we choose a particular approach for a particular patient. So it cannot be one standard treatment for all. So to summarize, I will say you should have a thorough knowledge about clipping and coiling techniques, both if possible. Teamwork along with the ICU staff is the best way to manage the aneurysms, because as I said, the surgery is in the first 24 hours of the patient's arrival to your hospital, but the rest of the stay for the next 2 to 3 weeks or 1 month, you'll stay in the ICU. And that's why, especially for poor grade aneurysms, it's important to collaborate very well with the neurocritical care. And that's an important part. And as I said, decision-making is a key dilemma for hybrid neurosurgeons, especially for equivocal aneurysms. And it has to do with the particular patient's anatomy and morphology. So that will change every time a new subarachnoid hemorrhage comes in, every time you are tackling a new aneurysm. So that's all. And I would like to thank you, everyone. And if anyone has a question, I'll be happy to answer it.
Thank you very much, Professor Ashish Kumar, for this very nice and complete presentation about a difficult topic. So I would like to ask the commentators to give some comments about this topic, Professor Apio Antunes and Professor Dilshad Mammadaliev.
Well, is it my turn now?
Yes, please, Professor.
Okay. Well, congratulations for the presentation. It's very objective, very on the point, as we say. I would like to hear from the panelists 2 or 3 special topics which I understand are very important for neurosurgical nurses, which is, I understand, is the main object of this presentation. First of all, according to the incidence, which is very nice, interesting paper at the beginning, I think the incidence, the low incidence in Africa and Americas, in South America, maybe is underestimated report. It can't be so low and so much lower than in Africa, I mean, in Japan and Europe. So maybe this is our wrong way of reporting illnesses. The second point is, in our department, 95% of cases we use angio-CT. We don't use angiography. In very few cases we do it because it's enough for diagnosis. But I have 2 questions, or 2 comments for the panelists and speakers. First of all, I didn't hear about the moment of the operation, which I think is very important. And second thing, especially for the nurses, which are the very special care we have to take with patients presenting with external ventricular drainage, especially the position of the drain according to the position of the head of the patient, manipulation of the system, velocity of drainage, etc., which is the thing that especially nurses do it every day in intensive care unit. And the second or third question is, as for control of operated aneurysms, we use ICG, of course, but in case people do not have it, I think angio-CT postoperative is enough for 95% of the case. So I would like to hear from the panelists the opinion about these topics. Thank you.
Thank you. Ashish, do you want to reply?
Yes. Thank you, Professor Antunes. Yes, I know. I think because this topic was overall management of subarachnoid hemorrhage, I didn't go into specific details about the EVD position, but I think that's a very important point you make, because when the EVD is inserted in either at the bedside or in the OR, the sterility of the EVD and the position of the EVD so that you don't overdrain or underdrain, especially before the treatment, is a key point. So normally what we do is we keep it around 10 to 15 centimeters above the external artery meatus and make sure that the patients are not overdraining. And sometimes, because this is a very early hydrocephalus, we want to make sure that the levels are way above 15 centimeters above the external artery meatus, so that before the aneurysm is secured, we don't overdrain, because there have been, of course, as you know, that there have been some incidences where it has been drained too rapidly, has led to aneurysmal rupture. So in my opinion, we do EVD bedside most of the times prior to the treatment. For definite prior to the treatment for endovascular management has to be there, because if suppose when you're coiling the patient in a ruptured situation, you are liquefying the clot because of the heparin which is going through the saline bags during our catheters are in the arteries. So it's important to control the ICP with the help of an EVD, because after, in case there's an intra-procedural rupture and you need to reduce the ICP, at that time, if you put in an EVD, patient already has heparin on board, and that can cause to a big ICH if you do it as a salvage maneuver. So it's important to understand that fact. For all endovascular obliteration of aneurysms, all the cases, we do an EVD like 2 hours or 3 hours before the procedure, and so that we have a full control on the CSF drainage. And of course, if the patient is hydrocephalus, it will also reduce the ICP even prior to the surgery. So it's very important. We use the Cocker's point most of the time to insert the EVD, and again, as I said, the EVD stays for almost 1 week to 2 weeks in the ICU. If needed, we probably, that's the usual time period, but if needed, we'll change the EVD after 1 week to reduce the chances of infection, ventriculitis, meningitis. So that was the answer for the first question. And the second one was, again, the same post-op CT. We also do post-op CTs, but the problem with the CT at sometimes is the small little residuals which you don't see. So again, as I said, 90% of time it will work well. If there is a clear neck, it's not a complex aneurysm, CT angio post-op also is sufficient. But in really some circumstances where we know that there will be multiple clips, especially if it's an MCA, we have used the fenestrated clips, and in that situation, DSA becomes important to see. But again, those are rare. As I said, those will be like 5% of all the cases. So majority post-op CT CT angiogram will actually do the job.
Yeah, I think the key point of EVD is actually important. There is a lot of discussion about this. Of course, I think we all agree that for very compromised patients, we need to place an EVD before the procedure. Should it be endovascular or surgical? For surgery, we use the Cocker point or sometimes also the Page point, the intraoperative placement of EVD. The point is, what's your management of patients who are not clinically impaired, like GCS 15 or 14 with ruptured aneurysm without hydrocephalus? Do you always place an EVD before endovascular treatment, or in some cases you avoid it? Because I think this is really the key point of management for those patients. And I agree with you, Professor Ashish, saying that if you place an EVD before the treatment, you must be very careful in how much CSF you are draining. So usually when we place it before the treatment, we keep it at 15-20 centimeters from the tragus, and we are very careful in releasing CSF slowly because of the risk of rupture.
Thank you. Thank you, Alberto. And I was also, focusing on this point in the critical care section where EVDs were used to reduce the ICP. But when you ask, when you ask about preoperative placement of EVDs patient with no hydrocephalus. I think that is not done even for the open surgical cases or for the endovascular cases. If there is no hydrocephalus, there's no point of putting an EVD prior to endovascular surgeries, because we are anticipating problems. If we are anticipating that problems, I think we should not do endovascular treatment, because if the aneurysm is that small that we are thinking that there can be an intraprocedural rupture, usually in those situations, many surgeons want an EVD in place as a safety measure. But the problem is, if there's no hydrocephalus, you are not able to put it in the right place, or you are not able to drain anything, or there's a risk of infection afterwards. So if there's no hydrocephalus, regardless of open or endovascular treatment, there's no role for EVD. The EVD will only come if there's a mild hydrocephalus, and you know that the GCS of those patients are not 15 or not 14, and they are in between, I will say, 10 to 13. In that, and with association radiological finding of early hydrocephalus, in those patients we'll put EVD prior to the procedure and make sure that it is kept at least or above 115 centimeters above the tragus.
Thank you. And I would like also to hear the opinion of 𝒊𝒐𝒇, and maybe after that, Professor Yoko Kato. 𝒊𝒐𝒇, are you here? We cannot hear you. No. Apparently you are not muted, but maybe.
Hello?
Yes.
Am I audible?
Yeah. Now, yes.
Okay. Thank you so much, everybody, for organizing this wonderful conference. And thank you so much, Dr. Ashish. It's a good presentation about management of subarachnoid hemorrhage and complications associated with it. I have several questions because in our practice, some of this neurosurgical hospitals still use extracerebral hypothermia. Maybe this question is controversial. Maybe some centers they have some kind of benefit from this. What is your opinion about extracerebral hypothermia in the acute aneurysmal subarachnoid hemorrhage? And the second one is using the lumbar puncture in case of subarachnoid hemorrhage. There is a role of lumbar puncture, as all neurosurgeons know. The release of extra CSF will decrease the headache and may be beneficial. But is it proven, or is it a real benefit? Do we have real benefit from this? And thank you.
Thank you for your questions, Dr. 𝒊𝒐𝒇. In my opinion, if you ask me, there are papers and there is some literature backing up extracerebral hypothermia for better outcome in acute phases, but it is also depends on the policies at the center. Especially here, we keep our focus on normothermia, not hypothermia, when the patients are in ICU, even during the procedure, when they're given the bare warmers. It's important to make sure that the normothermia is maintained. So we focus specifically on normothermia, even in ICU, the same philosophy during the surgery, during clipping, we do the same philosophy. I think hypothermia is beneficial in some ways, but it has its own problems in systemic ways, like it affects the other organs, and sometimes the metabolism also gets, because we are, as you saw that we are looking at multiple organs when the patients are of acute subarachnoid hemorrhage come to the hospital. During the first part, the treatment is done surgically, but then the rest part of the stay is in ICU, and we want to make sure that there is adequate metabolism and there are no other complications like pneumonia and DVT and associated systemic sepsis. All those things, I think, is better managed with normothermia as compared to hypothermia. Again, as you said, this is controversial, so some centers may use it. Like back in India, I was not using it, and here also, I have not seen anyone using it. The second question was, sorry, what was your second question?
About lumbar puncture.
Yes, so lumbar puncture, I think the lumbar puncture is basically used here for diagnosis purpose. For example, a patient with sudden onset thunderclap headache comes, has a CT angio done and shows an aneurysm. So this is one situation where they do a lumbar puncture to look for xanthochromia. And if they see xanthochromia, they'll say, okay, this aneurysm is a ruptured aneurysm, not an unruptured aneurysm, even when you don't see acute blood on the CT scan. So that's the role in diagnosis when the CSF is sent for, for having a centrifuge and then to look for xanthochromia. The question you were asking was for drainage and to circulate the CSF. I think that lumbar drainage we do when somebody enters into chronic phase, and once the EVD is out, and we are thinking about ventriculitis or meningitis, if CSF diversion needs to be done at some point of time, and the patient has an EVD for 1 week or it has been changed once already, but you still need it to prevent the risk of meningitis. I think in that chronic situation, sometimes we keep the patient, if there's a communicating hydrocephalus, we keep the patient on lumbar drain, just so that the CSF picture becomes better and you can shunt them when it's needed in the chronic phase. But in all acute
management, yeah.
Yes, in all acute phases, we actually rely on EVD till the time we can rely on it. And usually most of the patients, they wean off the EVD in 1 week to 10 days. To maximum 2 weeks. I'm not sure if anybody has a different opinion. Would like to ask the panel too.
Okay.
If Professor Apio-Antunes or Professor Yoko-Kato want to add something about this?
Yes, just
Well, just before.
Please, Apio, go ahead, please.
No, just a few words. Yes, I agree completely. According to the lumbar puncture, we rarely use it, except in very special cases where there's a thunderclap headache and CT is negative, which is the main use of lumbar puncture. The lumbar drainage, we do use it in chronic case, our colleague said, in patients where you don't have the risk of meningitis, you have used the EVD. So we do use it in very special cases. But the last question I would like to make to everyone, and especially to Professor Kato, because we have people here in Brazil, in Italy, in Japan, in India, in Canada, and China. What is the best moment to choose to operate on a patient with subarachnoid hemorrhage? Thank you.
Apio, you ask the timing?
Yes.
Yes, the timing,
Yes.
yes. Well, in my opinion, at least at my institution, the earliest timing is the best timing. So usually we use this method immediately, as soon as possible, with some exceptions. Like if the patient is like GCS 14, 15, and he arrives in the late night, we wait 8 a.m. in the morning, the day after, because in that case, the balance between benefits and risks probably make us reasonably choose to wait a few hours, just a few hours, but with a fresh equipe, fresh team, relaxed team, to do such kind of operation in the early morning, day after. This is our policy in my institution. What about the other institutions?
Same as
Yoko-Kato.
Yeah, same as you. And just I want to ask Ashish, thank you very much for a wonderful talk. So just I want to ask, is there any breakthrough the treatment of the grade 5? Maybe until the grade 4, maybe we can treat. The recent technique is improved, but the breakthrough I still don't have for grade 5.
Correct, Professor Caro. I think grade 5 WFNS patients normally, when they come, actually that's an only exception where we don't treat them as soon as they come, because looking at the, sometimes looking at the patient, sometimes they're GCS 3. And here there's a lot of emphasis on the goals of care discussion. So that happens again along with ICU and the surgeons and the patient's family about the timing of surgery. So in these situations, sometimes, and these are not very common situations, sometimes we wait for the patient to improve from 3 to 4 to at least, I would say GCS 5, 6, or 7. Then probably there is a chance of open surgery or endovascular surgery. But the preference in these situations, which I've seen most commonly over the years, I'm not sure what's happening at other places, is to go for endovascular treatment and just secure the aneurysm as early as possible. But if suppose if it can be done, if it cannot be done, then it has to be open surgery. There has been some philosophies where they say you operate early regardless of the WFNS grade of the patient. But in our institution, we usually wait and to manage them medically, to see some improvement. But if there's no improvement, then the discussion goes in a different direction. And I don't think so we have answer to grade 5 hemorrhages, Professor Caro. I think it has remained the same, and it's a big challenge to manage these patients, because the outcome is really not good, and there's significant morbidities in future.
And Ashish and also other panelists, we have a question in the chat. How to prevent infarct in post-operative patients? I think the question deals with vasospasm. You mentioned about vasospasm. You mentioned also about the triple H therapy, which is debated nowadays. So maybe this is actually a point of great interest for nurses, as they have to manage this in frontline, right? So maybe we can give some advice about this problem.
Yeah, so delayed cerebral ischemia, vasospasm depends on the, as I said in the first few slides, depends on the clot burden as well. So if we see a very minimal amount of cerebral hemorrhage, the chances of that patient developing vasospasm will be significantly lower than someone who has a very high clot burden, like Fisher grade 4 or grade 3, which has a significant clot burden, has a high risk of developing future vasospasm. Now, vasospasm, as I said, acts at the microcirculation level. So the treatment also starts at the microcirculation level. So the treatment will involve maintenance of euvolemia. We obviously keep the blood pressure on the higher side once the aneurysm is secured. Our usual target is between 160 to 180 millimeters of mercury sometimes when it is secured. So we want to make sure that the blood pressure is relatively higher. We do not give too much fluids, but we want to make sure that the MAP is above 90 at all the times. We want to make sure that we do, as I said, we do CT perfusions at day 3, day 5, day 10. Again, this depends on various centers. At many centers, it's not done. And they are basically monitored with the help of a transcranial Doppler, and to see the relative velocity between the MC and the ICA, and to see if the post patients are developing vasospasm. So the use of nimodipine helps. And if suppose we see moderate to severe vasospasm, there is a role of IV milrinone, and there's a role of using vasopressors to make sure that the blood pressure still remains above 90, the MAP remains above 90. So use of vasopressors, use of IV milrinone, and in case if it is resistant to these medical management, sometimes we take the patient down to the cath lab and angio suite again to do a balloon angioplasty. So sometimes if we see a proximal vasospasm in the MCA, proximal vasospasm in the ICA, in the basilar, in the proximal PCA, they actually very well respond to mechanical balloon angioplasty, and improving the flow becomes much easier if we use balloon angioplasty. And along with that, when your catheters are in the ICA, we can give IA milrinone verapamil to improve the macro circulation. Of course, the micro circulation will get improved with the help of other associated ICU management in the form of euvolemia, normocapnia, and to make sure that the patient is adequately sedated and the blood gases are fine. They are not. There's no CO2 retention. There's no risk of infection. I think everything, as I said, in ICU care management, everything contributes to reduction in the cerebral blood flow, which will cause secondary brain damage and can cause infarcts in the post-op patient. So therefore, the overall management along with the neurosurgical management also becomes important.
Thank you, Ashish. Maybe Professors Antunes, Mphabaliev, and Kato want to add something about how they manage this problem in their institutions. Like, is there a blood pressure you suggest? This is important for nurses, I think. And also, do you treat radiological vasospasm, or you deal mainly and wait mainly for clinical vasospasm? This is another crucial point, I think. Please, Professor Antunes, and then 𝑑𝒓𝒐𝒇 and Professor Kato.
Well, very briefly, because we have an hour. We don't treat angiographic vasospasm. We treat clinical vasospasm. In our hands, this is unless the patient is symptomatic. The second point is we sometimes do treat with balloon angioplasty in very special cases where we couldn't make it anything in clinically treating the vasospasm, which is sometimes very complicated, and we do go for ischemia. And the other point, which I think I would like to hear from the other people, is: do you ever use in World Federation or Glasgow scale 4 or 5 patients, you do a protective endovascular partial treatment, and then you go, if your patient get better, for the operation?
You mean when there is an intraparenchymal hematoma, or?
No. The patient is yes, including intraparenchymal hematoma. The patient is very bad. We think, well, the operation is very risky at this moment, so we partially obstruct the aneurysm with endovascular treatment, and then if the patient gets better, go for the operation.
Okay, I got it. Well, I can start replying, then I would like to hear also the other people's opinion. In my institution, if there is an intraparenchymal hematoma, we do operation. Probably 99% of cases. If the patient is in very bad condition, so irrespectively of intraparenchymal hematoma, if we start with partial endovascular operation, then we wait. Then generally we tend to keep doing endovascular later on, with some exceptions. So maybe we can add positioning of flow diverter later on after the acute phase is over. So in that case, we can also introduce antiplatelets drugs. So yeah, we tend to do this. Yes, when we start with partial embolization, then we wait, and if the patient survives, we do something as endovascular generally. What about 𝑑𝒓𝒐𝒇?
Yes, in our institution, we also don't treat radiologically. Rather, we treat clinically presented vasospasm, and mostly with medications like nimodipine and spasmolytic like drotaverine and antithrombotic, antiplatelet agents. And blood pressure, usually we try to hold on degrees of 140 to 90 mercury degrees, and mostly this is triple H therapy. what we use. And maybe we are just developing the direction of endovascular neurosurgery, and maybe we go for these treatment procedures also, but we don't have experience regarding the treatment of vasospasm radiologically. Yes.
Professor Yoko Kato, do you want to add some comments? Can you please unmute?
Recently in Japan also, we do the first priority is endovascular, and maybe the partially embolization of the Appio mentioned maybe only the rupture point embolization, maybe 1 or 2 weeks later, then we additional coil, so no more the direct surgery. So at the beginning, the partially coiling plus lumbar drainage. That is, I think, good for the patient, very less invasive.
Thank you, Professor. Any other question or comment?
I just want to add one more thing, Alberto. Like during this, for example, if the patient comes in a poor grade and we see the morphology is very complex, for example. So at that point of time, I think this interval coiling is really, really useful. And when the patient gets better, then patient goes for open clipping. If suppose, for example, there's a complex MCA. So we know that, this will be very difficult to treat endovascularly. So you, as Professor Caro said, we just treat the rupture point with the help of balloons or with the help of dual catheters. We try to just secure it temporarily. But suppose if the aneurysm's morphology is that you can treat it completely endovascularly, so then in that situation, we go for the complete cure when the patient comes and is stable to undergo a procedure. So at that point of time, that's how the policy is a little different here. For example, there's a small neck, there are no branches coming from the aneurysm, we'll just go and treat endovascular completely. But those complex aneurysms, which cannot be treated with endovascular approach, where ideal treatment is surgery, there also we'll try to use endovascular treatment to partially coil it, just control the rupture point, followed by, if he gets better, at surgery at some point of time. So I think morphology of the aneurysm also plays a key role during that point.
Okay, thank you.
I think we have a very good interactive and very informative session. I think we should move on to the second speaker. Prof. Alberto, can you please do the closing remarks for the first session, please?
Yeah, sure. Thank you, Mrs. Cheng. I think we had a very nice opportunity today to have a picture of the current status of a very difficult disease. I want to thank Professor Ashish Kumar for the nice presentation, and also Professor Antunes, Professor Mamadaidiev, and Professor Yoko Kato for the very active discussion. I think what we learned today is that subarachnoid hemorrhage due to ruptured aneurysm is not just an event, it's a process. And we have to put much of an effort to cure the event, but not only the event. We have to take care also of the process of the disease, which is long-lasting after the event of the rupture. So thank you very much to all of you and to the audience for the nice discussion. Thank you, Mrs. Cheng.
Thank you so much.
Thank you, Prof. Ashish. Thank you, Prof.
Thank you.
Is Prof. Ashish and Prof. Just staying back for the second session?
Yes.
Okay. Shall I invite call upon my co-chair, Miss Christine, to
Okay, Miss Ye.
introduce
Yeah.
Dr. Angela, please.
Yeah. Thank you, Miss Ye. I'm Christine as a co-host. For the first turn will be given by the second chair. Please welcome Dr. Angela. Dr. Angela, are you there? Okay. Allow me to introduce the chair at second session, Dr. Angela Gunana Durai, Principal Jubilee Mission College of Nursing, Madonna Nagar Kachheri, Thrissur, Kerala, India, President Society of Indian Neurosciences Nurses. Please, Dr. Angela, the time is yours. Dr. Angela, are you there, Dr. Angela? Okay, let's we start to the second session. The first speaker is Ms. Shani. The topic is critical nursing care in the management of patients with subarachnoid hemorrhage. Please allow me to introduce the chair, the speaker, Ms. Shani. She is Senior Nursing Officer, 𝒓𝒐𝒇 Institute of Medical Sciences and Technology, Trivandrum, India. Please, Ms. Shani, time is yours.
Hello, everyone. Actually, we are out of time, so let me go to my presentation very quickly. Let me take a minute to share my presentation. Okay. Is it visible? Okay. Myself and Shani.
Yes.
I'm in charge of neurosurgery ICU of 𝒓𝒐𝒇 Institute of Medical Science and Technology. It's in India, the southernmost part of India. So I'll be just introducing about aneurysmal subarachnoid hemorrhage, and then I'll be narrating on the nursing care tips for the particular each and every complications associated with aneurysmal subarachnoid hemorrhage. Frankly, I will say my presentation will be just a summary of the discussions happened just previously, because I'll be covering the ICU management of patient. It is seen that 85% of the cases of non-traumatic intracranial hemorrhage is due to ruptured aneurysm, and the common risk factors are hypertension, cigarette smoking, and heavy alcohol consumption. Even though the common site of aneurysm, intracerebral aneurysms, are near the circle of Willis, near the bifurcation, the common site of rupture of aneurysms are in the takeoff of the posterior communicating artery from ICA. That's around 41% of the ruptured aneurysms are in that site. Next come the anterior communicating artery, and then the middle cerebral artery. The interesting fact is that 20 to 30% of the people are having multiple aneurysms, and it's a sudden devastating event. Aneurysmal subarachnoid hemorrhage is a sudden devastating event with severe cardiac and neurological consequences. Yeah. So sudden with severe cardiac and neurological consequences in the immediate period, and the peak period of mortality and morbidity is in the first 2 weeks. And this injury can be due to from the initial hemorrhage, vasospasm, cerebral ischemia, or because of rebleeding. And prevention of rebleeding and optimization of medical management to counteract the cerebral vascular dysfunction is crucial in preventing these long-term complications. Usually, this aneurysmal subarachnoid hemorrhage patients presented with a sudden onset of severe headache, and there will be associated photophobia, blurred vision, neck stiffness, nausea, or vomiting. There may be focal neurological deficits, or even third or sixth nerve palsies may also be present. This may be due to the aneurysmal compression of the nerve root, or maybe due to the increased intracranial pressure. There may be associated loss of consciousness or even as altered level of consciousness. Sometimes patient may present with seizure, weakness, paralysis, agitation, or even restlessness. This Hunt and Hess scale or a WNS scale are commonly used to grade the severity of aneurysmal subarachnoid hemorrhage based on the clinical presentation. I am not going into detail of this. When a patient presented to your unit with this aneurysmal subarachnoid hemorrhage, our initial intervention is to secure an airway. We have to start supplemental oxygen to maintain a saturation of more than 95%. If you feel that the patient is unable to protect his airway, then you can go for artificial airways, or even mechanical ventilation may be required to maintain an adequate saturation level. Immediately after the bleeding due to sympathetic activation or stress or anxiety, patient's blood pressure may be elevated. So you have to institute measures to reduce the blood pressure to maintain in a normal range. Usually, potent beta blockers such as labetalol injections can be given in the casualty or in the intensive care unit to reduce the BP. Meanwhile, you have to establish minimum 2 large bore intravenous cannulas, and at times, if you feel that it is required, an intensivist will put central venous catheters or arterial catheters for monitoring and for sampling. Meanwhile, again, you have to draw blood samples for coagulation level, renal function, liver function, hemogram, etc. Because you may be anticipating the patient may be posted for an interventional procedure or a surgical procedure, or even some radiographic investigation. So we have to keep in mind while taking blood as well as securing intravenous catheters to the patient. You have to start some intravenous fluid, and the goal is to maintaining euvolemia. Usually fluids are started approximately at 2 ml per kg per hour. The fluid options are usually normal saline with or without 20 milliequivalents KCl. And we have to prepare the patient for an angiographic procedure also. In the casualty, you have to avoid intramuscular injections, enema, or non-steroidal anti-inflammatory medications, because these may trigger a rebleeding. Plain CT scan will show the blood in the subarachnoid space or in the ventricles, and in the scan itself, the surgeons will quantify the amount of blood to grade the severity of aneurysmal subarachnoid hemorrhage, and there will be signs of early hydrocephalus that can be seen due to as enlarged ventricles or dilated posterior horns of the posterior lateral ventricles. And if the patient presented to casualty with convincing clinical symptoms and there is no blood in the CT scan, it's already discussed, the surgeons may go for a lumbar puncture. And after 12 hours following clinical presentation, xanthochromia can be demonstrated in the CSF that will give evidence for an intracerebral hemorrhage. And here also we had a discussion previously. Conventional CT angiogram with three-dimensional reconstruction will give an exact or approximately better characterization of the aneurysm, its size, morphology, locations, adjacent vessels, neck size, and etc. But some patients, there may be small aneurysms in the base of the skull or a posterior portion. In that circumstances, a DSA can be selected by the surgeon for diagnosing this condition. Now, I'll be discussing about the early complications. I have already mentioned that this is a devastating event with a lot of cardiac and neurological consequences. There are some of the complications I'll be explaining. The tips for nursing care in the ICU to early identify and to tackle these complications. One of the important complications in the early period is rebleeding, then hydrocephalus, seizures, delayed ischemic deficit due to vasospasm, autoregulatory failure, or intravascular volume contraction. The surgeon's primary goal is to exclude the aneurysm sac from the intracranial circulation while preserving the parent artery. But the nurse's role and goal is to facilitate the surgeon to facilitate the surgeon in recognizing and to accurate diagnosis of the condition, and to facilitate in the treatment and rehabilitation process. And they have to stabilize the patient in the casualty and preventing the complications and early recognition of the complications. These are the nurse's role and goal. A serial neurological assessment is required to identify early deterioration in this patient condition, because early identification can prevent subsequent mortality and morbidity. The neurological assessment should include GCS monitoring, cranial nerve examination like pupillary response, extraocular movements, facial symmetry, corneal and gag reflexes, motor strength, motor tone, and sensory assessment. And we have to observe for any seizure activity and observe for the signs and symptoms of increased intracranial pressure. And following this aneurysmal subarachnoid hemorrhage, there are a lot of cardiac events are also observed, because there will be a marked reduction in the cardiac contractility with ECG changes are observed in some of the patients. So they require continuous ECG monitoring, and a frequent determination of blood pressure is also required. And the fluid balance has to be monitored by maintaining the intake output chart, and the volume status can be ascertained by monitoring CVP or a pulmonary capillary wedge pressure if there are facilities, and electrolytes and BUN need to be monitored, and osmolarity, urine specific gravity also need to be monitored in the intensive care period. And the neurovascular studies like a transcranial Doppler can be done to identify the blood flow status and to identify the vasospasm. And this near infrared spectroscopy will also give an indirect estimation of cerebral blood flow. And I'll be coming to the first complication, that's rebleeding. And the risk of rebleeding is maximal in the first 2 to 12 hours. And there are a lot of risk factors for rebleeding. Some are the persistent elevation of systolic BP over 160 millimeters of mercury, large aneurysmal size, or worse presentation of the patient. And there are a lot of other factors also. So what we need to do is, blood pressure need to be maintained within less than 140 millimeters of mercury in the initial period, and the mean arterial pressure can be maintained around 70. And if the pressure is elevated, some of the medications like labetalol or other Nicardia can be given to reduce the blood pressure. And sometimes the bleeding may be associated with coagulation problems. So the reversal of maybe if the patient is on warfarin or some other bleeding problems, that anticoagulation need to be reversed. And the factors, some of the factors associated with rebleeding, such as a cough or a Valsalva manual, that should be minimized. And one special point is that if your patient is on external ventricular drainage, that is an EVD, we have to carefully monitor the drainage of EVD, because rapid drainage of the CSF may lead to a rebleeding. So we have to be very careful about draining the EVD catheter. And the excessive stimulation of the patient should be avoided, and a headache and pain should be controlled with an adequate analgesics medication, and restlessness and agitation also need to be prevented. And one of the definite, as already discussed, the definite management of prevention of rebleeding is secure early obliteration of the aneurysm as possible by either surgical or intravascular means. The next complication is increased intracranial pressure. Already discussed some points about that also. Why we are worried about increased intracranial pressure is that if it persists for more than 20 millimeters of mercury for a long time, it can lead to cerebral ischemia and herniation. That will again cause additional mortality, risk of mortality and morbidity to the patient. So while as a nurse's point of view, we have to maintain the head end elevated to around 30 to 45 degree, and the head should be positioned in a neutral position, and sharp flexion or rotation should be avoided to aid in venous drainage, and legs should be placed straight, and hip flexion should also be avoided. And this reverse Trendelenburg position can be given while feeding the patient in order to prevent, rather than elevating the head to more than 45 degrees. Then usually the surgeons prescribe hyperosmolar therapy to reduce the intracranial pressure. Usually drug is mannitol, around 0.25 to 1 mg per kg can be given to increase the osmolarity of blood, so that it will cause an osmotic diuresis. It will, a single dose of mannitol will reduce 52% of ICP within 5 to 10 minutes, but the effect lasts for only 4 hours. And if the intracranial pressure is persisting, the next option is the ventriculostomy, in which the catheter is inserted into the ventricle through the Cocker's point. Usually what we have to do is, while caring a patient on ventriculostomy, we have to follow strict aseptic technique, and that drain should be open as specified by the neurosurgeons, and the bag should be positioned as per the recommendation by the surgeon, either at the point of ragus usually we place, so that the both pressure within the ventricles as well as the bag will be equalized, or we can elevate or reduce as per the direction of the surgeon. And usually continuous or intermittent drainage is practiced, In continuous drainage method, a fixed amount of the CSF is drained at a fixed rate. But in intermittent drainage, around 10 to 20 ml per hour can be drained at a time. That's the intermittent method. And the drainage of around 3 ml of CSF will reduce approximately 10% of baseline ICP for 10 minutes. And we have to monitor for the signs and symptoms of increased intracranial pressure every hour. And we have to maintain the ICP within less than 20 millimeters of mercury if there is a provision for monitoring ICP. And if the ICP is elevated and the patient is showing the signs and symptoms of increased ICP, a neurosurgical resident should be notified. And as I already told, if there are provision for ICP monitoring, that is good. But systematic review showed that there is no difference in the mortality or morbidity status of patient in both group, either ICP monitoring is done or not. But we can see that if a method is available where continuous and precise monitoring of ICP is possible, that will be promising in the advancement of neuro-intensive care, because the effect of each and every nursing intervention or other interventions can be, the effect on ICP of these interventions can be monitored, and we can plan accordingly the care of the patient. So that will help in keep continuously maintaining the ICP at a lower range. And if the ICP is sustaining at a higher level, sometimes the surgeon will go for a controlled ventilation in which the PCO2 can be maintained within 30 to 35 millimeters of mercury. Here also we have to observe for the signs of cerebral ischemia and with one ABG analysis, frequent ABG analysis and observance of patient. And in addition to that, for reducing ICP, adequate analgesia and sedation need to be given to the patient. And the patient need to be given stool softeners to avoid straining at stools. The next complication is acute hydrocephalus. Even though acute hydrocephalus is seen in around 15 to 87% of patients, only nearly half of the patient only will go for a chronic shunt-dependent hydrocephalus. This problem is evident with the presence of headache, nausea, or a consciousness disturbance in consciousness level. Sometimes the surgeon will go for a lumbar or a ventricular drain to reduce the hydrocephalus or ICP. Usually this drain is weaned off within 1 to 2 weeks, but sometimes patient may go for a chronic shunt-dependent hydrocephalus in which they will be managed with a shunt surgery. Now, another important complication of following aneurysmal subarachnoid hemorrhage is vasospasm. More than 70% of the patients develop vasospasm, but around only 20% will progress into a symptomatic vasospasm. And this vasospasm seen following this aneurysmal subarachnoid hemorrhage is not simple constriction of the blood vessel. The pathological process following this bleeding may lead to the development of constriction of the blood vessel in such a severity that there will be a reduction in cerebral blood flow. So it is called a delayed ischemic neurological deficit rather than simple vasospasm. The usual occurrence is between 3 days after the bleed to 21 days after the bleed. The peak time of incidence is in 5 to 14 days. In order to identify this vasospasm, we have to do serial neurological examinations. And the interesting fact is that the neurological signs may be vague, such as a global decline in responsiveness. And these focal deficits, such as hemiparesis, hemiplegia, or language disturbance, may wax and wane. And sometimes the baseline condition will mask these signs and symptoms also. And serial measurement of blood flow velocity in the bedside with TCD may help to identify vasospasm. Sometimes in suspected patient, catheter angiography can also be done to identify vasospasm. And already discussed by the previous speaker that the amount of blood in the subarachnoid space is a strong predictor of vasospasm. So there are interventions to reduce the amount of blood by inserting an EVD to drain the excess of CSF. To drain the blood as well as CSF. So if you drain the CSF, the blood will also be get drained up. Usually for symptomatic vasospasm, The more specified interventions are reserved for symptomatic vasospasm, but some of the interventions are in the form of preventive to prevent the development of vasospasm in the intensive care unit. So one of such intervention is insertion of an external ventricular drainage and starting of nimodipine around 60 milligram orally for every 4 hourly for 21 days, or while the patient is hospitalized. This nimodipine can be given as an infusion also, and studies have shown that both have almost equal effect in preventing vasospasm. And sometimes the nimodipine tablet we can't give at a stretch, that is 60 milligrams. So a small dose can be given at frequent intervals. That is 20 mg every 2 hourly can be given, so that blood pressure can also be maintained. Then some of the other preventive as well as treatment type of intervention include, we have to avoid hypotension, because if the patient is in vasospasm, we have to maintain euvolemia and adequate blood pressure to maintain cerebral circulation. And the patient should be well hydrated, a positive fluid balance, or at least equalization. The intake should be equalized with the output, or at least 500 in a 20 plus in a 24-hour period is usually recommended for this type of patients. The dobutamine or milrinone may also be advised to infuse for this patient to maintain the cardiac output and cerebral blood flow. Sometimes the surgeon will specify the target blood pressure as well as CVP based on the age and sex of the patient, and considering the comorbidities in the patient. Usually the blood pressure I already discussed, it should be around mean arterial blood pressure should be around 70, and CVP can be maintained 8 to 10. And here also the definite management is early repair of aneurysm within 1 to 3 days by surgical or endovascular means, because the incidence or the incidence of vasospasm will start after 3 days. So if we secure the aneurysm within 1 to 3 days, there are more options for the surgeons to counteract with the vasospasm, because blood pressure can be elevated without complication of rebleeding. A lot of other options are there for surgeons if they obliterate aneurysm within 1 to 3 days. And for a symptomatic vasospasm which is not responding to the preventive type of and other modalities of treatment, more aggressive treatment modalities are opted, that is a catheter or angioplasty and direct installation of a vasodilator medication to the spasmodic blood vessels. This image shows that vasospasm in the blood vessels, and after milrinone infusion the blood vessel is dilated. The second image. Okay. A few words about 𝒓𝒄 therapy. Previously, the 𝒓𝒄 therapy of volume expansion and induced hypertension hemodilution was strongly recommended for preventing or treating vasospasm, but because of its cardiac and pulmonary complications and lot other metabolic complications, this therapy is not at all advised widely. Now, what they recommend is a form of hemodynamic augmentation in the form of maintaining euvolemia and to maintain a elevated BP. That is around 15% of baseline BP can be elevated to maintain a level of 140 to 160 or 160 to 180 to the maximum according to the patient status, so that perfusion can be maintained. One of the other complications of this aneurysmal subarachnoid hemorrhage is hyponatremia and intravascular oleum contraction. And following a stage, around 1/3 of patients develop hyponatremia. And this hyponatremia and intravascular oleum contraction seen in aneurysmal subarachnoid hemorrhage is termed as cerebral salt wasting. What we have to do is we have to maintain a positive fluid balance. And usually we restrict free waters, and oral liquids can also be limited, and enteral feeds can be given as concentrated form. And if hyponatremia is not responding, supplemental enteral feeds can also be, enteral salt can be given. And if the hyponatremia is persistent, the surgeon may order for a hypertonic solution, or even there won't be much requirement for 3% is saline infusion, but mildly hypertonic solution can also be infused. And one of the other important nursing responsibility is to prepare the patient for a surgical intervention as and when indicated. The usual surgeries are decompressive surgeries or a hematoma evacuation, or the definitive surgery of aneurysm clipping, or sometimes they may plan for a coiling. In all these conditions, we have to prepare the patient for the procedure. And efficiency of coiling and clipping already discussed, and we can also see that the surgical interventions are superior for obliteration of aneurysm from the cerebral circulation, even though it is associated with little bit higher mortality and morbidity than the intervention procedures. In the other general care points include, we have to maintain a blood sugar of less than 180 milligram per deciliter in the ICU, and we have to prevent hypoglycemia also for the patients. And a sodium level should be maintained within 135 to 146, and magnesium can be more than 1.8. Then regarding hematological parameters, if the patient is having any coagulopathy or coagulation problem, that can be reversed with FFP or a cryoprecipitate, or sometimes vitamin K can also be administered. And here also the temperature, normothermia is advised for these patients, because there are potential complications associated with hypothermia. And if the patient is having a persistent temperature of more than 101.5, then some associated with, may be associated with some infection, so cultures need to be taken. Our goal is to maintain normothermia, because hypothermia increase the cerebral metabolism and further damage the brain. And regarding nutrition, it has to be addressed within first 24 to 48 hours after admission. But most of the time, patient may be NPO while waiting for imaging procedures or a neurosurgical plan. But we have to start as early as possible. Enteral feeds can be started as early as possible. And generally, all these patients require seizure precautions. For that, sometimes antiepileptic medication need to be given, and the railings should be always on, and the flashes of light and unwanted alarms should be avoided, and patients should be given a calm and quiet surroundings. The role of steroid is not much accepted, but sometimes it can be given to reduce the meningeal irritation and postoperative edema. And for this patient, strict infection control practices need to be observed, because these patients may require a prolonged ICU stay, and there are infections associated with EVD, that is EVD related ventricular meningitis. The patient is at risk for that. So we have to follow strict aseptic techniques in the ICU. A few words about the prevention of the subarachnoid hemorrhage. One point we can highlight is that the common cause of bleed of the aneurysm is high blood pressure. So we can advise the people with high blood pressure to regularly take their medication to reduce the risk of bleeding. And tobacco and alcohol misuse can be avoided to reduce aneurysmal subarachnoid hemorrhage. And it is seen that there are some aneurysms due to this connective tissue disorders and all. There is a family history for that, so the immediate relatives need to be screened for the presence of aneurysm. And even there are a chance of multiple aneurysms in same patient, so that also need to be screened and intervention to be done to prevent further bleeding. To conclude my presentation, subarachnoid hemorrhage is a complex disease, and already it is told that it is a process with prolonged course that can particularly challenging and rewarding to the intensive care nurse. And the overall mortality ranges from 32 to 67%, with around 10 to 20% of the patient left the intensive care unit with long-term dependence due to brain damage. And the management options are still limited to the manipulation of systemic blood pressure or alteration of blood volume. Even though we have other surgical techniques to obliterate the aneurysm, the process of post-bleeding process, the management option is still limited in these aspects only. With that, let me stop my presentation. Thank you. Thank you for listening.
Thank you for Miss Shani. Next, we go to second speaker, Miss Suchitra. The topic is aneurysma subarachnoid hemorrhage, a case report. Miss Suchitra, Nursing Officer, Neurosurgery ICU, Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, India. Please, Miss Suchitra, the time is yours.
Thank you, ma'am. Thank you for inviting me. And a pleasant good evening to all. And let me share my screen. So myself, Sujitra PV from 𝒓𝒐𝒊𝒕𝒊𝒄𝒂𝒍 Institute for Medical Science and Technology, Trivandrum, India. And the topic is the case report on aneurysmal subarachnoid hemorrhage. So about the introduction, so in the previous session, we already heard the cerebral aneurysm or intracranial aneurysm is a cerebrovascular disorder in which weakness in the wall of a cerebral artery or vein causes a localized dilatation or ballooning of the blood vessel. So we already heard. So my patient was a 65-year-old female and she presented with complaints of headache, which was sudden in onset, holocranial, continuous, and rapidly progressive, and which was aggravated by noise. And she had multiple episodes of vomiting, and which were non-bilious and non-projectile in nature. She had also complaints of neck stiffness. So she had a sudden severe headache and multiple episodes of vomiting, and also she had neck stiffness. So at first, she was taken to a local hospital, and there an imaging was done, and which revealed diffuse subarachnoid hemorrhage. And she was referred to our center for further management. So at the time of admission on examination, she was conscious, alert, with stable vital signs, and her GCS was 15, that is E4, B5, M6, and her higher motor functions were normal, and her pupils were bilaterally equal and reactive. And her extraocular movements were full, and visual fields were normal by confrontation, and fundus examination revealed no papilledema. And bulk and tone of the muscles were normal in all 4 limbs, and her power grade was 5/5 in all 4 limbs, and she had no sensory or cranial nerve deficits. So her WFNS score, that is World Federation of Neurosurgical Society score, was grade 1 because her GCS was 15. And all the blood investigations sent from OPD itself, and all investigations were normal. But her CT brain neck angio, which was done under stroke protocol, and it revealed diffuse thick, that is more than 1 mm sulcal hyperdensity noted in the perimesencephalic cistern, bilateral CP angle cistern, sulcal spaces, cerebral hemisphere, and it was along with the intraventricular hemorrhage extension. So she had a diffuse thick, that is more than 1 mm bleeding with intraventricular hemorrhage extension. So her modified Fisher grade score was 4. But the CT angio didn't reveal any aneurysms or abnormally dilated vessels in the intracranial circulation. So we couldn't identify the reason for this SAH. So, but we suspected an aneurysmal rupture. So we posted the patient for emergency digital subtraction angiography. So an emergency digital subtraction angiography was done on the day of admission itself. And this angiogram revealed a postero-superiorly directed 1.6 into 1.2 mm sized saccular aneurysm, and which was arising from the origin of right pica, that is right posterior inferior cerebellar artery. So she had a saccular aneurysm, and which was arising from right pica. So this was the angiogram report of my patient. This was the saccular aneurysm. Its size was 1.6 into 1.2 mm, and it was arising from right posterior inferior cerebellar artery. So this is the circle. This picture depicting the circle of Willis, and this is the posterior inferior cerebellar artery. It is a branch of vertebral artery. So pica aneurysms are very rare condition, and it accounts only 3% of all the aneurysms. So my patient had a saccular type of aneurysm. This is very common comparing to fusiform and dissecting type of aneurysm. And this saccular type of aneurysms are more common with the subarachnoid hemorrhage. So my patient was diagnosed as a case of saccular pica aneurysm with SAH. So the preoperative period, it is very crucial because in this period there is a high chance of rebleeding. So we should, this rebleeding may lead to increased mortality and morbidity. So the preoperative period is very, very important. And my patient was cared in intermediate care ICU, and we checked her vital signs and neurological examination we did very hourly. Unfortunately, all her vital signs were within normal limits. This is very important because if the systolic BP in this period is more than 150 mm of mercury, that may lead to rebleeding. And to avoid rebleeding, we provided bed rest to her with a head of bed elevation by 30 degrees, and we provided a quiet, calm environment with a lower level of external stimulation. And we avoided all painful procedures like IM injections and enema to avoid rebleeding. And we attached a cardiac monitor because the SAH may be associated with the cardiac arrhythmias. As she was on bed rest, we applied sequential compression devices to prevent deep vein thrombosis. And my patient and also the relatives were very anxious, so we provided psychological support. So in the preoperative period, all her vital signs were normal, and we provided bed rest with a quiet, calm environment, and we avoided all the painful procedures. So in the preoperative period, she was medically managed with calcium channel blockers to prevent vasospasm, and we gave tabinimodipine 60 mg for 𝒓𝒊𝒕, and we gave anti-epileptics to prevent seizures. 𝒓𝒊𝒕 500 mg BD was given, and she had severe headache. That's why we gave injection paracetamol 1 gram IV TDS to relieve headache. And we gave laxatives to prevent straining and to avoid increased ICP. We gave 𝒓𝒐𝒻 50 ml HS. So the early surgical or interventional treatment is very, very necessary to prevent rebleeding. But in case of pica aneurysm, this surgical or interventional treatment is very difficult because of the deep location of the pica and also its close proximity to the brainstem and lower cranial nerves. Here we have two options. The first one is open surgical clipping option, and the second one is endovascular therapy, coiling or flow diverter. And we preferred open surgical or clipping for my patient. And the surgery was done. It was an emergency surgery, a midnight surgery. So craniotomy and clipping of right pica aneurysm was done. And after surgery, patient was received to neurosurgery ICU. And after surgery, she was on ventilator, but she was conscious, alert, and she was moving all four limbs. And her pupils were equal and reacting to light. And her SBP was maintaining above 140 mm of mercury. And we maintained 100 ml positive per shift. And her CVP, central venous pressure, was around 8 to 10 centimeter of water. And injection pneumotop was on floor, that is 2 ml per hour infusion was on floor to prevent vasospasm. So in the immediate postoperative period, checking vital signs, level of consciousness, and motor function is very, very important. So we checked her blood pressure, pulse, level of consciousness, pupillary responses, and motor function hourly, and we recorded it in our neurological observation chart. We elevated the head of bed to 15 to 30 degrees, and we maintained an intake output chart. But unfortunately, she developed signs of lower cranial nerve palsies. She had poor cuff and gag reflex. So we did an elective tracheostomy in view of prolonged ventilation and also to prevent aspiration. But she was very conscious. She was obeying. She was very cooperative patient. Her GCS was E4, VT, and M6. On day 6, we gradually weaned off her from ventilatory support and we shifted her to ward. But on day 7, unfortunately, she developed sudden onset of left hemiplegia and we suspected vasospasm, and we posted her for emergency digital subtraction angiography. And a DSA was done, and which revealed bilateral MCA bifurcation vasospasm, which were more on right side than on the left, and a balloon angioplasty was done on right and left MCA, and flow was established. And after that, a chemical angioplasty was done to the posterior circulation with the injection mildrinone. And this mildrinone infusion was continued post DSA. And after DSA, patient was received to neurosurgery ICU. So she had a prolonged hospital stay for about 3 months because CT brain showed a malignant right MCA and ACA infarct. For that, right decompressive craniectomy and lax duroplasty was done. And she had an emergency EVD insertion in view of hydrocephalus. And she had a drop in GCS while clamping EVD, and for that left braces BP shunt was done. So she was in our hospital for 3 months. So about the nursing consideration, I already told this patient was in our hospital for 3 months. So managing her, she was on and off ventilator for 3 months. So managing her airway was a difficult task for us. And she was very prone for ventilator-associated pneumonia. And to prevent ventilator-associated pneumonia, we gave a propped up position. That is head of bed elevation to 30 degree. And we cared her oral cavity with the chlorhexidine. We also cared her oral cavity with the toothbrush and toothpaste. And to prevent stress ulcer, we gave injection Pando 40 mg BD. And while she was on ventilator, we did sedation assessment, and we gave spontaneous breathing trials with the TPs and O2 masks. And we gave DVT prophylaxis with the help of sequential compression devices, and also we gave early ambulation to this patient. We ambulated her to wheelchair with the help of a hoist machine. And she also had a tracheostomy, and we gave frequent suctioning, nebulization, humidification, etc. And she never developed a ventilator-associated pneumonia during her hospital stay. And we were able to shift her to the ward with the tracheostomy room air. And also she never developed stress ulcer and deep vein thrombosis during her 3 months hospital stay. And about the skin care, she was a bedridden patient for 3 months, and we provided frequent position changing. That is, every 2 hours we changed her position, and we cleaned her skin with the soap and water. And also we give back massage with the moisturizer. And also she never developed a single skin abrasion during her 3 months hospital stay. So she had an external ventricular drainage, and if the patient, when she was in supine position and head neutral, we leveled the EVD system to the tragus of the ear. And every time we moved her, we re-leveled this EVD, and we checked the drain status, drain height, hourly output. And we recorded it and checked the dressing status, and dressing she kept dry and intact. And we used aseptic techniques while handling EVD. And about the nutrition, I already told this patient had a lower cranial nerve palsy and her gag was very poor. But we tried semi-solid ones, but she couldn't tolerate. So we gave rice to feeding. That is, we did a dietary consultation, and we gave high protein, high calorie diet through rice to with the help of a diet chart which was prepared by our dietitian. And this, because of this long hospital stay, the bystanders were very anxious, and we gave psychological support to the bystander, and we gave some family time for her, and we included one of the family member during physiotherapy. So at the time of discharge, she was conscious and febrile, and she was on tracheostomy room air and was on rails 2 feet, and her GCS was E4 VT M4. And her pupils were equal and reacting to light, and her wound was healthy, staples were removed, and now she was on regular follow-up in neurosurgery OPD, but her GCS remaining the same. This was a research study about the complication and outcome of patients with aneurysmal SAH. It was done in Netherlands. This study revealed that 43% of patients had poor outcome, and the cerebral ischemia had occurred in 28% of population, and the major causes of poor outcome were the effects of the intracerebral hemorrhage and rebleeding. So by concluding, aneurysmal SAH is a worldwide health burden with a high fatality and permanent disability rate, but early therapy we can prevent rebleeding. And the delayed cerebral ischemia, usually due to vasospasm, it is a serious complication and is associated with the adverse neurological outcome. So the nursing care of the aneurysm patient is very challenging. So close observation of their neurological status helps to prevent complications related to rebleed and vasospasm. Thank you.
Thank you. Thank you for Ms. Shani and Ms. Suchitra for the completed and nice presentation. And Now we go to the Professor Apio and Professor 𝑑𝒓𝒐𝒇 for opinion and commentator, please. Thank you.
Thank you so much for very detailed and very informative presentations. Both presentations were very accurate and to the point of patient management in subarachnoid hemorrhage, especially the management of patient care and from the perspective of nursing care. And I should confess that without nursing care, we cannot treat any patients. And the nursing care is the most crucial in especially in intensive care units, especially in the resuscitation units and pre and post-operative periods. And I just acknowledge the effort made by both of you for preparing this presentation, and it was very detailed, and the medical treatment and the steps of algorithmic management of treatment were mostly the same in our institution. I think generally taken, it is mostly the same with other institutions also. Thank you.
Thank you, Professor 𝑑𝒓𝒐𝒇. Any question for participant? If you have question, you can raise hand for the second session.
Ashish?
Maybe
Okay.
Prof. Ashish may have something to say.
Thank you so much, 𝑚𝒄𝒻𝒻𝒻. Thank you so much, Professor Caro. Yeah, I mean, I'm glad that for that pica aneurysm case presentation, they chose surgery, because there will be few centers where they'll try to deploy a flow diverter. But that's where I think the fine line is, and patient who has already bled, for a flow diverter, you will require blood thinners, you will require aspirin and Plavix, which is not a great idea when there's so much blood in the vein already. So I think it was an amazing case, managed very well. And of course, unfortunately, patient developed a bad vasospasm, and that's something which you can control only up to a certain limit. And that was a good example of you doing balloon angioplasty and chemical angioplasty. So great presentation. And the first speaker actually showed us about all the nuances of overall medical management in the ICU. And to be frank, some of them are so detailed that probably I don't know. But I was very well surprised by the fine details of nursing care which our patients receive. So as Dr. Dilshad said, very humbly appreciate the effort done by the neurosurgical nurses in management of our patients. So both talks were amazing. Thank you so much.
Thank you, Prof. Ashish. What about Prof. Alberto? Any comments?
Yes, I also appreciated a lot these presentations. I think what we heard just confirms the conclusions of the first session. What I said is this kind of problem is a composition of two problems. An event, which is the aneurysm rupture, and this part, of course, in this part, the neurosurgeon is the main actor. And there is a second part, which is the process of subarachnoid hemorrhage, which is not less important than the event of rupture. And in this second part, in the process, I think nurses play a crucial role. So we must join the efforts between doctors and nurses to try to, overcome this very, very difficult part of this disease. So thank you very much for showing us this part of the problem.
Prof. Kato, would like to comment?
Thank you so much. We learned a lot from both nurses. And also, I think the nurse is always beside the patient. They has a lot of chance to find something wrong with the patient. I think the theoretical base, and also you should learn the change of the not only the patient's condition, but also you should learn the how to read radiological film. I think you can learn from each other, the doctor, the communication, I think, in between the nurse and doctors. So I think you should treat the patient with the knowledge about the mechanism of the disease itself. So that's very important for nursing care. I always admire your effort to take care of the patient. Thank you so much. Wonderful session.
You, Prof. Kato. I do believe it is a teamwork. Nursing the aneurysmal subarachnoid hemorrhage patient is together with the surgeons. It is a teamwork. I think nurses themselves were not able to do. So we have to work together. And the crucial thing is nurses must be able to detect drop in GCS. That is very crucial to prevent further deterioration. That is my point to the nurses. I think with that, any question from the audience?
I think I saw the 𝑝𝑎𝑟𝑡 from Afghanistan.
Yeah. Would you like to comment something?
Konbanwa.
Konnichiwa. Thank you. Thank you, Professor Kato and Cheng, Ashish Kumar. It was very interesting and very important session. And we are also faced with subarachnoid hemorrhage patient, and we agree with you. This more take care of nursing and ICU care is important, very important. And we see this nursing take care of, and we proud of our good nursing as well. And I will invite our neuro ICU nurses to attend in the future webinars as well. Thank you.
So Fawad, just I want to ask. Yes. Hi, Fawad, can you hear?
Hi.
Hi.
Thank you.
No, just one nurse. How many patients she can take care? The ordinary ward.
And the ICU.
One nurse. How many patients she or he can take care?
It's dependence, and the ICU, we have one nurse and one bed, but in the wards it's 4 or 5 beds per nurse.
That's nice. Good condition, you see.
Yes. Okay.
Thank you very much.
Thank you. You're welcome. But we need also training for our ICU, and especially neuro ICU nurses as well.
Good.
I think the nursing care for these patients everywhere will be the same. It's the same actually. Yes. So it is more of a team work, team effort to have a better outcome of patients. So I think with that, if there's no further question or comments, can I call upon Professor Yoko Kato to give us the closing remarks, please?
So today we had a very good webinar, especially the Ashish Kumar. He's a specialist of the subarachnoid hemorrhage. So he is a specialist of the endovascular. Maybe the next time he can show us how to treat the subarachnoid hemorrhage patient by endovascular. Ashish, is okay?
That's perfectly fine, Professor Kato.
Okay, thanks. Thank you very much. And also the two nurses, the lecture, that was perfect. So I think you can, your knowledge transfer to the younger generation. Please educate them. Thank you so much. It was wonderful, the webinar. Thank you very much.
I think with that, we have had a very interactive section, and thank you very much, everyone, and hope you all have enjoyed the session. I learned a lot from the session today. So till we meet again, our next webinar will be on the 19th of March. So I will keep you all informed what are the topics. Okay. I think thank you again.
Thank you.
Bye. See you again.
Thank you.
Thank you.
Thank you.
Bye bye.
Thank you,
Bye-bye.
Professor. Thank you, Dr. Professor Tur.
Assalamualaikum.
Assalamualaikum.
This shot, are you fine?
Yes,
Arigato.
thank you.
Are you working
Yes,
today?
yes,
Okay.
night shift, yes.
A nice shift. Okay.
Yeah.
So